So today I want to continue with talking about hypertrophic cardiomyopathy. Continuing from last class. As I said before, hypertrophic cardiomyopathy is caused by a mutation of some of the sarcomere complexes. So anything within the sarcomere, whether it's actin, myosin, or anything related to it, can cause, so any mutation there can cause problems and can cause hypertrophic cardiomyopathy. Some of these mutations are known to be kind of very pathological in the sense that it leads to arrhythmias and heart failure at some point. Some are a little bit less, many are unknown. There's still many that we don't know, so there's still a lot to be known. But when it becomes clinically, so when it becomes kind of, when we say it's like a positive phenotype in some ways, what we see is that these patients come in, and when you do imaging, you see these extremely thickened hearts, predominantly in the septum, and then that even can be so thick that it actually will cause outflow tract obstructions. And what we also know is that it is related to some late gadolinium enhancement, predominantly mid-myocardial. So let's try to understand this a little bit better. And then also, because one of the things that we need to do is we need to try to do kind of a differential diagnosis between other kind of types of hypertrophy. So where we see a patient with a thickened heart, and to try to know whether it's really hypertrophic cardiomyopathy versus, for example, hypertension induced, or there's some other kind of mutations or deposition disease, for example, that can cause thickening of the heart. And let's first see, for example, how you're going to approach this. So as we said before, the HCM is being caused by a sarcomere mutation or infiltrative. So we can come back to that. And then secondary is mainly predominantly pressure loaded. So although a lot of things look similar, and there again also there's a spectrum. So of course, if you have this patient with this enormously thickened asymmetric septum and things like that, very likely it's going to be a hypertrophic cardiomyopathy. But if you have a patient which is like, okay, it's a little bit thickened and it's mainly the basal septum which is a little bit thickened, then of course it becomes much more difficult in order to look at it. So then we need to find ways to and understand why these hearts look a certain way, and find ways, of course, to try to make this diagnostic, try to find especially imaging ways in order to look at that. So the first thing that we will see, and we will come back in detail, but what I've already said last time, is what you see is like, because of this sarcomere mutation, what seems to happen is that there is that the myocardium develops in such a way that you have this fiber disarray. So that you do not have this kind of nice fiber orientation anymore, that would be normal. And then on top of this, and then especially also depending on the age of the individual, you might have more or less fibrosis there, which then potentially might lead to late enhancement, for example. But especially in the beginning, in younger individuals, you will most likely not have a lot of fibrosis and no late gadolinium enhancement, but you do have this fiber disarray. So you will have this abnormal microstructure, but with myocytes which are normal in brackets. Of course, they will be hypertrophied because they will be kind of overloaded. They will have very, very high wall stresses, but the tissue is in principle normal, except of course for the configuration. While, for example, when you see in hypertension, so there's no reason why hypertensives would have a different fiber structure, because most of them is secondary hypertension. So that means that hypertension develops later in life, for example. And what you then see is that you get much more fibrosis deposition. But I'll come back to that later. So while there's a lot of things in common, because of the fact that they have very different underlying substrates, what you can actually see is that there's probably some phenotyping that we can do, and especially when we look at deformation. So when we're going to try to look at regional strains, for example, and see how they change throughout the heart and how this relates to the underlying tissue, because you can already imagine that tissue which is very kind of disarrayed will contract very differently from the one that just has fibrosis on top of a normal structure. And this is what we're going to go in a little bit more detail. So what do we have available if we would try to do this based on ultrasound? So as I said, you can do an MRI. With MRI, you will see the geometry, and you can look at late enhancement. We'll come back to that later on. You can also do like T1 mapping, for example. But still the workhorse of imaging, of course, in this setting is, of course, echocardiography. And keep in mind that with echo, we have a lot of different ways to look at hearts. So obviously, in this case, looking at structure and seeing whether there would be some hypertrophy. So what the size of the chamber would be, because what you expect in these patients is that they very often they have very, very small cavities with very, very thick walls, and that might be asymmetrically or not. So looking at the shape and the thickness and the size is quite important. But besides that, obviously, we have more information. One of the things is, of course, flow. And even the color Doppler is very important in these patients because, as I said before, if the wall becomes so thick that it actually starts to partially obstruct the outflow tract, so partially kind of the thickness of the wall is kind of almost overlapping partially with the aortic valve. What you then see is that it becomes an obstruction, and then you really see that you see flow acceleration there, for example. So that type of flow is already quite interesting. But then obviously, what you also want to look at is you want to use the flow for the inflow, because also when you have a lot of fibrosis, when you have a lot of fiber disarray, very likely the overall elasticity is going to change. Plus, as we said before, the contractile function or the deformation during contraction, and thus the storage of the energy that is needed, so the elastic energy or the spring energy, whatever you want to call it, for the early relaxation is going to be changed. So very likely, if you have tissue changes, you will have filling changes. And that's what you very often see also in these patients, of course. And looking at the outflow, obviously, if you have an obstruction of the outflow, definitely your velocities will increase. And as we said also in some of the previous lectures, what you see also is if there's an overall inability of the heart to contract properly, so that means that if overall the contractility goes down, what you very often see also is that the peak of your aortic flow is being delayed. So that actually the force development is longer in order to compensate for the lack of contractility in order to overcome the loading. The other part, which is used clinically more and more also, is looking at the tissue Doppler velocities. So see how the ring moves. As we said before, that helps also for filling, but also that helps for ejection. And this actually tells us something about overall the longitudinal function in some ways. And then, of course, we can look at deformation imaging, where speckle tracking is the most used, and we can really look at regional changes. And we will see actually that looking at the regional deformation changes in this setting is actually quite powerful. So what do we need to do is if we want to try to interpret the deformation, as we said before, it's like there's many things that actually contribute to what this deformation looks like. Obviously, the pressure will contribute. And again, in these patients in hypertrophic cardiomyopathy, you would expect normal pressures, except, of course, when you start to get this outflow tract obstruction, then you actually get kind of a stenosis there in some ways, which, of course, will increase the ventricular pressures. So we need to have an idea on whether that's normal or abnormal. The overall geometry will play a role. And what we see there also is when you look at these hearts, they become mostly very small. So the hypertrophy is going towards the inside. So because it decreases the cavity, because then, of course, also due to kind of when you look at the Laplace stress, you will see that the smaller the cavity, the lower the stress will be for a certain pressure. Keeping in mind that these hearts, if they have all this fiber disarray, of course, have decreased contractility there. So then obviously the intrinsic contractility is important. And this is a thing that we haven't been talking about too much, because what you will have is intrinsically you have a sarcomere mutation. So that means that intrinsically it might be that you have a abnormal contractility. And that's a little bit the question also, is how much this plays a role. So is it that in the end they have problems because primary there's a decrease in contractility, or is it that kind of this primary during development there's a slightly decrease in contractility, which makes that the heart develops very differently, and you start to have this fiber disarray, and then in later life it's the fiber disarray which is the biggest problem. This actually we don't know, but this is a thing to keep in mind, that contractility is obviously one of the problems that might be modulated because we intrinsically work with the Sarcomere mutation. And then obviously the tissue abnormality is really important because that end changes how the force of the individual myocytes is either working together or working against each other, and then is contributing to the pressure buildup. But also, of course, the tissue characteristics make the kind of the passive mechanical properties, and especially the passive elastic properties, make it different, which is again very important for filling. And then, of course, what we never should forget is segment interaction, because we never see a heart which is kind of overall globally with fiber disarray, because I think these fetuses, when in fetal life, are just not viable. So these people are just not being born in some ways. So there will always be differential changes in the different segments. So what you then need to do is try to figure out a way to kind of discriminate all these patients. And so here, for example, are 4 different patients where we have a very normal or very normal looking heart, although there is some kind of mutation. And here we see a much more abnormal heart, where we also see much more changes in the other parameters, and you can have things in between. And so the question is, do they have all genotype typical changes? Because one of the things is like here, if you have a negative genotype, so you try to do a genetic analysis, thinking about hypertrophic cardiomyopathy. When it's positive, obviously, you know what the mutation is, and some mutations are worse and others are less worse. But if you get a negative result, actually, you don't know, because we test this with arrays mostly. So what you do is we are actually testing for known mutations. And unless you would do like a kind of full genome analysis, which is mostly not done and which is still kind of not always feasible and not always at very high reliability, we don't know if there's any mutation in the sarcomeres that might be important. So when it's negative, you have to think about alternative ones, but you should never discard, for example, that there still might be a mutation. So we need to find ways in order to understand why they are different and how they are different. And so what you will see is, like, of course, as we said before, there are tissue abnormalities. So one thing is, okay, sample tissue, but of course, in many patients, this is not feasible. So it's only, for example, when they undergo surgery, because of the fact that they have such a thick wall that you get this obstruction and the surgeon is going to cut away tissue, then you have tissue. Or in some very rare cases, you would do a biopsy, for example, but mostly you would not do. So what you need to work with is the information that you can get kind of much more or less invasively. So obviously family history is something important there, because since this is a genetic mutation, just asking what the history of sudden cardiac death, for example, or heart failure is in the family will tell us something. Many signs and symptoms can be useful. Keep in mind that they're never very specific. So what you will have is, okay, you might have a symptomatic patient or a patient that once in a while has something that could be attributed to hypertrophic cardiomyopathy. But again, this is mostly not specific. So if you would have one with a thick heart because of hypertrophic cardiomyopathy, it might be that you have, in a way, similar symptoms as somebody that has, for example, long-standing hypertension or something like that. So there's quite a lot of overlap. Then, of course, genetic testing might help. But keep in mind, it's like, although in the past, people have been saying like, okay, if we genotype and we find this mutation, we know everything. Unfortunately, that's not the case, because what we see is that people that have the same mutation, exactly the same mutation, seem to have very, very different phenotypes, or at least clinical courses. It could be that with the same mutation, you have zero problems whatsoever, and you never get into trouble, and other ones are very, very symptomatic and need treatment. And we still don't know why or what is causing this, whether this is something fetal or whether it's modulating during life by other factors or things like that. Are there environmental factors which are important? We just don't know. And then, of course, we can go in a little bit more detail into non-invasive imaging, and that this is where we can try to be a little bit more specific. And just to remind you, and we've been discussing this when we talked about pressure loading. So what we see, for example, is if you have pressure loading, for example, hypertension, but any pressure loading in the ventricle, what you will see there is that actually, because of the geometry of the ventricle, we start to see predominant changes in the basal septum. So you see very often a little bit of hypertrophy there. So you might have this basal septal hypertrophy. But what you mostly see is that the basal septum will start to get potentially a little bit of stretching in the beginning of the ejection phase, and then has less systolic deformation followed by post-systolic deformation. And the post-systolic deformation is because of the differential loading, and thus the kind of differential combination of contractility versus the loading of different segments. And then you start to get segment interaction at the moment that the pressure drops. While in normal hearts, everything is very, very homogeneous. So this is important. So to know, okay, if it's normal, we know deformation is homogeneous throughout the walls, and this is kind of universal. If it's related to pressure loading, what we will see is that especially the apical parts and also mostly the lateral parts are more or less normal, while we see that there would be starting a gradient with a decrease of systolic function the more we go towards the base, but always a decrease followed by post-systolic. Because intrinsically, we still know there's contractility. So that means that there still has to be a little bit of contraction. It's only less contraction compared to the surrounding segments, and then you start to get this segment interaction. So the question is, what is now happening with the hypertrophic cardiomyopathy? And so here's an interesting study that Philip Lonsrich actually did for his PhD. And what we did there is we took patients that had obstructive hypertrophy. So that means that there was hypertrophy of the septum that made that the outflow tract was partially obstructed, and they needed surgery in order to relieve that. So, and from this, we did all the imaging, we got the genotyping, and also what we did is, so we got, of course, echo and MRI, and also what we did is we got the tissue that was being resected, and then we have been looking in really detail to the microstructure of this. And so here you see some examples. For example, also, let me just say, how this was done. So we acquired the data using synchrotron phase contrast imaging, so X-ray phase contrast imaging, and at kind of medium resolution and at very high resolution, where you can really see the individual cells. So all of these are cells which are myocytes, which are cut in their kind of circumferential, in their short axis in some ways, and you see some vessels, and you see the fibrosis going there also. Now, one of the things that you see also is, like, when you look at the sample, for example, you see also that the endocardial part, you see here that this is this kind of very bright white compared to the tissue. So it's clear that there is already some endocardial damage or endocardial fibrosis, maybe fibroelastosis. So what happens is there likely is that, well, either this is because there was some problem with perfusion and you got kind of necrosis, but that is unlikely in the endocardium. What's mostly happening is that when you have this outflow tract obstruction, what actually happens is that the mitral valve, and because of a Venturi effect, but we can discuss that in another session, but what happens is that the mitral valve during the outflow, the open mitral valve is actually being sucked towards the wall and is actually hitting the wall with every heartbeat, you get this. And so it seems that there you get some local damage of the endocardium. And so that's what you can see there partially. Now, if we go to two different patients, what you see here is that these patients, so we have a patient 1, patient 2, one with a positive genotype, one with a negative genotype. Keep in mind, this is not necessarily saying that there is no, but it might be. But one of the things that you got here is that there was clear hypertension in this one. Well, actually, there was a combination of hypertension, diabetes, obesity. So we know that this is like the very typical high-risk cardiac patients that have quite thick walls. So you really see that there's quite thick walls. And if we look at the MRI, what we see there is, like, I mean, at first you don't see a lot of late enhancement, but you might say, okay, here, locally, you see that there's a little bit of subendocardial late enhancement. While if we look at this patient, so this patient is a genotype positive one. So this is a very well-known mutation for severe hypertrophic cardiomyopathy. and without any kind of history of hypertension, but even with a history of some kind of arrhythmias. And what you see here now also, when you look at the late enhancement, you see that especially at the hinge points of the right ventricle with the left ventricle, you see this, but what you clearly see is that this is mid-myocardial late enhancement. So there's no sign of subendocardial late enhancement. But what is interesting is if we start to look at the deformation. So what you clearly see here is that these deformation patterns are very, very different between the kind of non-genetic kind of etiology and the genetic etiology. And what you see, for example, is that when we look here, so you see the different segments. So what we see here is this very typical pattern, as I said before, is that the more apical you go, the higher the systolic deformation, and you clearly see some post-systolic deformation. You even see some early stretch. So this is very, very consistent with the pressure loading, with the hypertension. And so it seems like a lot can be explained by the fact that this patient indeed was fully hypertensive. While when we look at this patient, what you now see is that the basal septal part is, well, it's clearly less, so there is less deformation. But what you see then, if you go a little bit more apical, you see that actually deformation is decreasing. And if you then even go more apical, it's increasing again. So instead of this pattern of the hypertensive, where you go from low systolic with post-systolic towards normal in some kind of a gradual way, what you see is in this hypertrophic cardiomyopathy, what you see is like there is deformation, although abnormal deformation, and then you have a region of zero, quasi-zero deformation, and then you go towards deformation again. So you see that this pattern, this regional pattern, is very different. So the localization of the pattern, so how the pattern changes from base towards apex is different, but also the part where you have the abnormal deformation is also very different. So here you have reduced systolic deformation, but you always still have systolic deformation in every segment. So even if this is a very thick wall, every part is at least deforming a little bit. While here you see that there's segments which are totally non-deforming at all. And then if you're going to look at the underlying tissue, then what you see here is that this is the hypertensive kind of patient. And what you see here nicely is that this is a very organized tissue. So what you see here is all these myocardial cells are aligned in the same way. As we said, we cut them in a short axis way, and they nicely form together in such a way that when they contract, they will actually interact with each other, or they will help each other in order to do end force development in one direction and the deformation in one direction. What we see though is that you see here these white lines. So this is actually fibrosis, and this is more than normal. So you see pressure loading, you get higher loading there locally, you get also more fibrosis. So that means that the tissue becomes a little bit more stiff, but at least you have a normal microstructure together with normal contractility. That means that there can be some systolic deformation. Now, when we look at the other patient, so this is the genotype positive patient, when you look here at these cells, it's like, I mean, you're cutting every cell almost in a different direction. So you really see that these cells are totally crisscrossed. There is no overall kind of organization in this. Plus, one of the things that you also see is like, you see there's quite a lot of vessels. These vessels are like larger. They are much more irregular. And you see here like vessels with very, very thick walls. So this tissue is totally abnormal. But on the other hand, what you also see is like these really white structures you don't see. So there is no kind of increased fibrosis in this one. So it's really normal cells, but the normal cells are just totally disorganized. And of course, now you can already imagine that the cell, as we said before, if a cell is oriented in this direction, is contracting, what it wants to do or what it needs to do is, of course, it will shorten, but it needs to thicken because of conservation of volume. If at the same time you have a cell in the other direction, which also wants to shorten and thicken, then of course, the thickening of this cell is stopped by the shortening of the other. So that means that overall, although they will develop a lot of force, or maybe even, as I said, might be even reduced force because of the sarcomeres, but at least they will develop force. But besides the force development, they cannot deform because of the fact that they are counteracted. So what's happening there in this piece of tissue is you have contraction in some way, so you have forced development of the myocytes, but overall you do not have any deformation, but of course you have extremely high wall stresses, or at least extremely high cellular stresses, which then cause the hypertrophy. And also then in later age, so when these patients become older, then they do get fibrosis because of course, at some point these myocytes give up, they start to die, get enough apoptosis, and are replaced by fibrosis. So you see already from when you understand the underlying tissue, you can already imagine what the deformation would be, or the other way around. If you see a certain deformation pattern, where you see regional areas where there's no deformation whatsoever, but it doesn't look like there's a lot of kind of fibrosis there, then you know that that has to be because of this fiber disarray. Yeah? So this is quite important. So in that sense, it's like we can use this to understand what the hypertrophic cardiomyopathy is causing in the underlying tissue and how this would impact deformation. Or of course, when we measure deformation and we know about the impact, we can try to infer non-invasively the underlying tissue. And that's what we do here in this case. Huh? So here you see it again, kind of a little bit summarized in some ways. Huh? So what we see in this hypertensive is we see the subendocardial late enhancement. And it's also because this little piece of tissue that I showed you before with this white layer, that is actually from this patient. So you see the subendocardium is damaged with a combination of very long-standing pressure loading and the impact of the mitral valve, of course, with every heartbeat. The underlying tissue is structurally normal. However, there's quite a lot of fibrosis organized, very organized fibrosis. The whole tissue is organized. This combination means, together with then the geometry-related loading, means that locally in this basal part of the septum, you have less deformation plus post-systolic deformation, but you still have deformation. While when we look at the hypertrophic cardiomyopathy, you have absolute total fiber disarray. When you look at the collagen, also the collagen goes everywhere. So there's absolutely no organization. And because of this, you will have regions where you have no deformation whatsoever, independent on the amount of fibrosis locally. It's mainly this fiber disarray that causes it. But what's also important is that you do not have a gradual change, but you really have a sudden change where you have these tissue abnormalities. So this way you can get an understanding from looking non-invasively and knowing the cardiac mechanics as a result from underlying tissue structure, what's going on actually. Now, this brings me to how you look at this in clinical practice and how do you do research about this. So for that, I want to come back to when you look at the classical way echocardiography is being done is, of course, you have the typical views. And then what is being done is that according to the guidelines, every view, you divide the chamber into 6 or 7 segments. And you really report or measure, if you want to quantify these segments separately. And we do these segments also because we partially know that these segments are mostly attributed to certain coronary arteries, because of course, echocardiography, by the fact that coronary artery disease is the majority part of cardiac abnormalities that we see in patients, of course, a lot of this is towards this trying to recognize cardiac coronary artery disease. And for that, these segments are very, very useful. Eh? But if we now start to look at a patient with fiber disarray locally because of likely fetal development, and where the position of this fiber disarray and the extent of this fiber disarray is very different in different individuals, it's predominantly in the septum, but we don't know whether it's really in the base, the mid-septum, whether it's like just 5% of the length of the wall or 50% of the length of the wall. So if we then going to try to use these standardized segments, we come in problems. You can already imagine that, of course, if you compare one with a basal one and compare one with a mid one, and you're then going to do a study where you're going to average the deformations, for example, or even the thicknesses over these standardized segments, of course, that makes no sense. But this is what a lot of people are doing in the literature. And the result is, of course, that when you look in the literature towards hypertrophic cardiomyopathy, what they say is that the septal segments are reduced in deformation. Well, obviously they are reduced because what you will have is you will have patients with smaller or larger amount of absolutely zero deformation. And of course, when you start to make averages of this, you see on average it's reduced. But on average, it's not zero, of course, in these segments, because these segments do not correspond to what's the underlying morphology. So I think this is a problem and causes also a bias in understanding in the literature, which is actually true for all diseases which are not related to these segments. And one of the things which I think is also important is that these segments were made at a time that the resolution of echocardiography was also not that great. So then if we had these coarse segments, that would be fine also. But by now, actually, our machines are much, much better. So now, actually, these segments are starting to become partially problematic. Now, another thing related to these segments, and I might have mentioned that before also, is like one of the things is also, of course, when you visually score segments, as has been done and still is being done in a lot of echocardiography, what you can do is, of course, you assign abnormalities to a certain segment. Even if it would extend a little bit into the other segment or be smaller than that segment, what you do is you can nicely attribute it to different segments. Of course, when we're trying to use more objective ways and we're going to measure things, then of course you cannot attribute it to the segment. You have not much flexibility with the size of these segments. So then if you start averaging this by the computer, it might be more problematic. Or also, if you want to match different patients, you want to say like, okay, do these patients have common things? And one has like a little bit of a smaller segment, which is a little bit more apical. The other one is a little bit more basal. Then, of course, although these segments have very, very similar properties, at the moment that you average it based on this kind of localization, you start to get in trouble. So this is, I think, really important when you look at literature that is doing regional reporting based on segments, and it's an underlying etiology that might not be fully related to these segments. You might kind of miss something, or you might smooth out some things. There are ways to overcome this, and one way is to overcome this is, first of all, not work with these segments, but work with patterns. For example, if you say like, look, we have this pattern where deformation is changing from kind of normal or lower normal towards totally absent towards normal again, or go from kind of decreased systolic with post-systolic towards more normalized. So if we can put this into, explain this into patterns, then it could be useful. Or another thing is also, and this is a paper that was done at some point by Gemma Piella based on MRI tagging in these patients, what you could actually do is also try to make abstract of these segments and try to see is like, okay, how are these deformation patterns, how are they distributed in some ways? So if you would make, for example, a histogram of deformations that are available irrespective of their place within these hearts, what you then see, for example, is if, of course, if you look at controls, they will have normal deformation. So this is both radial and circumferential because it's based on MRI. You see that the normals have a very nice small distribution because all the segments are contracting or deforming in a similar way. When we look, for example, at some hypertensives, for example, what you could see there is, okay, you have some reduced deformation, for example, but at least, again, there might be a little bit of a distribution or a little bit of widening of the distribution, but it's very often a shift of the distribution itself, not a fully widening. While when we look at the hypertrophic cardiomyopathy, what you now suddenly start to see is that you have a distribution where you have segments which are quasi-normally contracting and segments which are totally abnormally contracting. And so you see really that by looking at this, at these distributions, you can actually also already try to discriminate patients. And of course, this type of approach, by the fact that it's independent on the localization, this is a lot more easy to then do statistics on as compared to something which is based on these segments. So here again, when you either do the analysis yourself and you want to report this and do statistics, or when you want to read papers and try to see how we can translate that into clinical practice, this is what you have to keep in mind. And so looking at distributions, or looking, for example, not only at averages, but also at standard deviations, you will see that there's a lot of information there. And quite interestingly also is like, here is in these patients also, we looked at the late gadolinium enhancement, and what you see there, for example, is that there is some kind of correlation between the late gadolinium enhancement and the thickness, but with a very wide spread. So it's not necessarily that only the very thick regions have late gadolinium enhancement. Keeping in mind, for example, what we said is that, for example, the intersection, so of the right ventricle and the left ventricle, there we very often have late enhancement, but we rarely have extremely thick walls there. So there we really start to play with changes in local wall stresses that at some point might induce late enhancement. Again, keeping in mind that late enhancement is not necessarily fibrosis, but is kind of a altered dynamics of the accumulation locally of gadolinium. So there again, this can be related partially to the fiber disarray, or can be related to long-standing loading, long-standing high wall stresses, for example. Okay, so very, very briefly, I'm going to finish with this. I'm not going to go in detail now. We might go into some other way of doing it. So what kind of modality do we need to use here? As I said, it's like echo, but only when you're using to try to specifically look at patterns of deformation. I think is very, very useful to look at hypertrophic cardiomyopathy. In general, the echo measurements are not always the easiest or the best in these patients. If you just do geometry, then maybe it's not always that reliable. We know that MRI is much better in measuring detailed geometry. The question is whether this is important, because the geometry, as we said before, you have hypertrophy because of, in these patients, likely secondary to the fact that you have local fiber disarray, which induces very high wall stresses in the local myocytes, which have to hypertrophy in order to cope with this, or at least hypertrophy as a result of a stimulus because of this, and then the walls are starting to become thick. So in a way, this hypertrophy is of course secondary in some ways. Of course, late enhancement can quantify this better. MRI can quantify this better. And additionally, late enhancement can tell you something. But again, is it so specific? As I said before, because of this kind of, we don't know a lot about the dynamics of gadolinium in these cases. And for example, we have no clue what the exact reason is for this kind of late enhancement in the intersection of right and left ventricle, and whether this is clinically relevant also, we don't know. Nowadays, what you can do is you can do T1 mapping, where they try to, or what seems to be correlating with amount of local fibrosis. And what they say is like, you can measure extracellular space, which is again related to matrix alterations. This is not always a very easy measurement, and we can see these changes there also. But one of the things that you see again is, I think, trying to look at these very specific deformation patterns, which we know that come from the tissue together with the cardiac mechanics, I think is actually much more sensitive in some ways to look at. Again, then this is something we might discuss at some other point also. It's like, because of course I was talking today about hypertrophic cardiomyopathy versus hypertension, but there are still many, many other kind of reasons why you can get thickened heart. And sometimes by using it, looking at this, trying to measure fibrosis-like measurements or extracellular volume type measurements, you can get some differences. So MRI might be useful, but I honestly think that if we have proper ways to recognize these patterns in ultrasound, and ideally even automatically try to recognize these patterns, I think that's much more powerful, because that really goes back to the underlying microstructure, which is because of the underlying sarcomere mutation. Still a question whether this is really fetal, I think so, or how much is being kind of acquired later on. These are still things to look at. Okay, so the most important, I think, here is that you have to remember that in order to try to understand these hearts, you really have to go towards what's the etiology and what is causing this. So how is this causing changes in the tissue? How is this regionally potentially distributed? How homogeneous or heterogeneous is this? How does this affect deformation? Can we find patterns in order to do this? And how do we do studies trying to do statistics on these patterns? These are still things which I think are very, very crucial, and where there's still a lot of problems, especially in literature, in order to look at this. Okay,